So what are the common sleep disorders in older adults? In this section, I will discuss insomnia, circadian rhythm disorders, obstructive sleep apnea, and restless leg syndrome. Let's talk about insomnia. Insomnia is defined as poor or insufficient sleep for at least 3 nights per week for at least 3 consecutive months. And insomnia has different types. We have early insomnia, we have middle insomnia, and late insomnia. So early insomnia is usually characterized by difficulty falling asleep. Middle insomnia is equivalent to interrupted sleep, while late insomnia means that the person wakes up very early and they are unable to fall back asleep. And it's most common with depressive disorders. Insomnia can be problematic, and it's actually very prevalent in older adults. As we had mentioned earlier, up to 45% of individuals 64 and older have insomnia, and a third of them use sleeping aids. Age and gender are the most significant demographic risk factors, making elderly women the most vulnerable individuals in our community. So the treatment of insomnia has 3 main components. The first one is treating underlying causes, especially pain, using non-pharmacological methods which are safer and avoids polypharmacy in older adults. Last will be using medication, only if the non-pharmacological options have failed or have been deferred in specific clinical scenarios. Sometimes we have clients who have cognitive impairment, which makes using non-pharmacological therapies quite challenging. And in many cases, clients will refuse to engage in non-pharmacological therapies despite much encouragement. So let's talk about non-pharmacological treatment options. We have basic sleep hygiene and more of the manualized treatments. So sleep hygiene, let's talk a little bit about it. It involves a lot of basics based on the process C and process S that we had discussed in previous slides. So for process C, we tell our clients to treat their corneal lens opacities. They need a proper daily light and dark exposure, using light therapy, even a sun lamp. Establish a very fixed bed routine if possible. Keeping bed for sleep and sexual activity only. Meals and fluids need to end early in the day, and established fixed sleep hours, no variations between weekdays and weekends. How about process S? When it comes to process S, we offer our clients some advice like increasing social and physical activity during light hours. Avoid long daytime naps if possible. We ask them to limit their caffeine use only to light hours because caffeine is an adenosine receptor blocker. We ask them to regulate the temperature and try to rid of the environmental interference while they're sleeping. It's always helpful to have handouts in your clinic to give to your patients so they can remember and review after they leave your office. So let's talk about manualized treatments. There are several of them. I'll mention here a few. So the first and the most important one is the cognitive behavioral therapy for insomnia, CBT-I. The second is BBTI, brief behavioral therapy for insomnia, which is an abbreviated version of the same regimen, multi-component behavioral therapy, acceptance and commitment therapy, biofeedback interventions. So for CBTI, it's considered the first line of treatment for insomnia, especially in older adults. It involves 6 to 8 visits in the span of 8 weeks of cognitive therapy, stimulus control therapy, sleep restriction therapy, paradoxical intention, with or without relaxation therapy. For BBTI, it's only 2 visits in the span of 4 weeks, just focusing on stimulus control and sleep restriction and no cognitive restructuring. While multi-component behavioral therapy, it involves meaningful activity protocol during the day to keep you busy, with assisted relaxation therapy at night. So let's take a moment here and take a closer look at the cognitive behavioral therapy for insomnia. It is a manualized, time-limited intervention that includes principles of sleep hygiene, stimulus control, and sleep restriction. it is highly recommended by multiple organizations in America and the UK for treatment of insomnia, especially in older adults. In this section, I will go over the different components of CBTI and how it is structured. So we have 6 main components of CBTI. The first one is stimulus control based on classical conditioning, focusing on pairing bed with sleep. The second is sleep hygiene, controlling the environment and the behaviors that precede sleep, as we had mentioned before. Sleep restriction is partial sleep deprivation that we do deliberately with a goal to achieve consolidated sleep only at night. Number 4 is relaxation therapy, full of mindfulness interventions like progressive muscle relaxation, diaphragmatic breathing, hypnosis, and yoga. Paradoxical intention comes next, which is basically asking the client not to sleep, to lower their performance anxiety and help them initiate sleep. Cognitive therapy involves cognitive restructuring to reduce the perpetuating and negative beliefs and attitudes associated with sleep. It's proven to improve sleep latency, sleep efficiency, and sleep quality. So let's discuss a session structure. Of course, some variations exist between different practices, but they are more or less the same. They start with an intake session. You start with a chief complaint, history of insomnia, any sleep studies, the sleep schedule, any sleep hygiene factors, sleep-related anxiety and frustrations, psychiatric and medical history, and an accurate medication reconciliation, including OTC and herbal products because they impact our sleep. And request a sleep diary, which is super important for the rest of the sessions. So the first session, we review this diary, we educate the patient about CBTI, we start with stimulus control and sleep restriction. The second session, we go over the diary again, reinforce positive behaviors, and then revise the sleep hygiene. What did we do well? What needs to be revised? The third session, we introduce relaxation therapy to help them to initiate sleep. And we might need paradoxical intention for sleep initiation as well. Then in the fourth session, we review the diary, reinforce positive behaviors, and start introducing cognitive therapy, which should be continued in the fifth session. And then the last session should focus on reinforcing all the positive behaviors that the client had learned and discuss relapse prevention. Let's talk now about pharmacological treatments. There are many of them, and I'm going to classify them into FDA approved for insomnia, off-label psychotropics, over-the-counter options, and herbal and unregulated products on the market. So the FDA approved options for insomnia include the GABA A receptor agonists, or we call the Z drugs, like etsopiclone, zolpidem, zolpidem extended release, and zaleplone. We also have benzodiazepines like temazepam, triazolam, estazolam, flurazepam, quazepam. And keep in mind that these doses that I have put on the slide are the ones that are suggested for older adults. And also keep in mind that these options are approved for onset and maintenance of sleep, except triazolam and zaleplone, which are only approved for onset because of their short half-life. Other options include the dual orexin receptor antagonists, heterocyclics like doxepin, and melatonin receptor agonists like ramiltione for onset insomnia. Please bear in mind that the options with the red asterisks next to them are listed on the updated American Geriatric Society's Beers list in 2019, which means that these medications should only be used in older adults when benefits outweigh their risks. So what's the problem with benzodiazepines? Well, they are commonly prescribed in older adults, despite them being considered unsafe and should only be used at the lowest dose and the shortest duration possible. Why? Because they cause tolerance and dependence, which makes them hard to stop if needed down the road. It causes ataxia, increasing fall risk and impairing mobility in older adults. It causes cognitive impairment up to acute delirium, and they can cause fatal withdrawal if abruptly discontinued or missed due to cognitive impairment. So what about Z drugs? Well, these drugs are generally less problematic compared to benzodiazepines. However, you need to keep in mind that etsopiclone has drug interactions with other medication through the cytochrome 3A4, and zolpidem and even zolpidem extended release are slowly metabolized in females and older adults. The guidelines now state that they should be discontinued in the presence of any complex sleep behaviors. Now let's talk about the dual orexin receptor antagonist, or the DORAs. They are approved for sleep onset and maintenance disorders in adults. Sulfurexant got approved for insomnia and Alzheimer's disease in 2020. They all work through blocking both orexin receptors, which is involved in process C. They have side effects as well, which include impaired motor coordination, worsening of depression, complex sleep behaviors, and sleep paralysis. They can also compromise respiratory functions. However, they have not been fully evaluated in patients with sleep apnea. There are other medications in the pipeline, including pyromelatine, which is a melatonin and serotonin receptor antagonist, and it's currently being tested for Alzheimer's disease and related dementia patients. There are also more DORAs coming through. Now, take a quick pause. Now, take a pause and think. How would you start your conversation with a patient presenting with primary insomnia?